We know our healthcare system is struggling in this province. We need more staff, more support, and it's not unique to the rest of the country. A veteran healthcare analyst says he knows why we have this problem, and he says he has some solutions. Ones he knows won't be terribly popular. Stephen Lewis says primary care is failing, in part because doctors have too much say in what they will and will not do. They can choose when and where they work, what their specialty is, and what kind of patients they want. As a result, Lewis says it is leaving some big gaps. Today on Blue Sky, we're going to float his critiques by a panel of working physicians and a nurse practitioner, and we'll get their thoughts on his healthcare solutions. We also want to hear from you today. Should doctors be more regulated? Would that help more people find a family doctor? What's your experience been in primary healthcare? You can call 1-800-716-2221 or email us bluesky@cbc.ca. It seems fixing healthcare has become a national pastime, but for all the effort, millions of Canadians still do not have a family doctor. So what's the problem? Stephen Lewis is a health policy analyst who has spent decades pondering this question, and he's come up with a solution that he believes will work, but it might not be very popular. We'll hear from him, and then we'll convene a panel of people who are actually working in healthcare these days. Stephen spoke with Saskatoon morning host Stephanie Massicott, and she started by asking him about that solution he's come up with.
The solution sounds simple. It is, we need to actually create a primary care system that is attached to the rest of the system, meaning all the other services. And the key principle is, instead of primary care being essentially a cottage industry where literally hundreds and thousands of individual practitioners make their own independent decisions about how to practice, where to practice, how many patients to take on, that you run it like a system. The analogy would be, in some ways, you run it like a hospital where you have a certain number of physicians, you have obligations, you organize your services to meet the need, and it's basically all joined up. And in this case, in Saskatchewan's case, you would put it under the Saskatchewan Health Authority.
I mean, when you look at it, it seems pretty nice to be your own boss, making your own schedule. So how are you going to get doctors to support such a plan?
Obviously, this would be a monumental change from the way the system has been organized since the beginning of Medicare, or more accurately, disorganized or unorganized. You'd have to negotiate it, which is totally reasonable. So the Ministry of Health, the Saskatchewan Health Authority, and the Saskatchewan Medical Association would have to sit down and talk about why the system isn't working. Why is it that we have more family doctors than ever, yet more unattached patients than ever? Why is it that we can't, despite heroic efforts, ensure a reasonable supply of family doctors and other primary care practitioners in rural and remote areas? This isn't unique to Saskatchewan. This is a Canada-wide problem.
But can you bring about these changes without the participation of doctors?
No, absolutely not, which is why the Saskatchewan Medical Association is so critical. Everything has to be negotiated. There are lots of entitlements built into the system now. Any physician, for example, and let's stick with family doctors right now, a family doctor who the College of Physicians and Surgeons says is eligible to practice, fully qualified in Saskatchewan, is entitled to a billing number. So even if, for example, Saskatoon has enough family doctors, I'm not saying it does, but supposing it does, that person has a right to set up practice in Saskatoon and open the door, and as long as there are patients who will walk through that door, has a right to serve them and to bill for them. And if a family doctor can make enough money by serving 500 patients and giving them really good service, maybe even Cadillac service by seeing them very frequently and so on, that physician is entitled to do so. So a lot needs to be undone from some of these arrangements because what we have now is an incredible variation. Some doctors have literally rosters of a few hundred patients and others have over 2,000 patients. We don't know much about why that is. And is that a good thing or a bad thing? Are some doctors overserving their patients? Are some doctors underserving their populations, their roster, because they just don't have enough time to serve them adequately? And, when you start opening Pandora's box here, a lot of stuff flies out that you would want to fix.
I mean, we already are kind of struggling to keep doctors here in Saskatchewan. If the province were to move ahead with this plan and not everyone's on board, not everyone's happy, don't we risk losing a lot more doctors?
It's possible, but first, Saskatchewan has always lost a lot of doctors, and especially a lot of graduates from medical school. We have either the lowest or the second lowest retention rate of our medical graduates of any medical school in the country. But I think the reality is a lot of doctors aren't happy with the current system. Again, younger, newer doctors, they don't really want to be entrepreneurs, a lot of them, which is why very lucrative practices that are now closing because older doctors are finally retiring in their 70s and so on. They can't give those practices away, let alone sell them. So something's got to give here. I think there is pretty widespread consensus, including among doctors, that we need a different model. And I think everybody also recognizes that the Medicare is truly at risk if 20% of adults don't have a regular source of care. The problem, of course, is how do you get from where we are now to where we need to be?
Stephen, has this been tried anywhere before?
Not in Canada. So this will not be simple, even if you negotiate the authority to do so. I think there would have to be other major changes to get it done in Saskatchewan. For example, you would need to invest money in multidisciplinary, interprofessional primary care clinics in rural areas, but that are clustered. There is no way you're going to get a family doctor in every town in Saskatchewan. It's just not a sustainable model. So you want a polyclinic with doctors, nurse practitioners, RNs, occupational and physical therapy, and pharmacy and psychology. You want an interprofessional clinic that serves a few thousand people, so it's actually a good work environment, and you're not vulnerable to being on call 24/7. And if somebody goes away, the whole enterprise doesn't collapse. So really, first you need to negotiate some principles, like are we all committed to ensuring that there is primary care in every part of the province? And secondly, are we interested in changing the model substantially, which would require changes in how you fund the system and how you pay people?
We only have about 30 seconds left, but do you think there is the political will to bring about such change?
If there is, it's not evident. I mean, you don't hear it talked about much. Frankly, I think governments are afraid to do this because organized medicine is extremely powerful, and they don't want to get into a pitched battle over something that medical associations have woven into their DNA about autonomous practice and so on. But at some point, I think a government may decide to do this because they may start to pay a political price for not solving this problem.
That was Saskatoon Morning host Stephanie Massicott speaking with Stephen Lewis, who is a health policy analyst. So, is there truth to his theory? And what are the solutions? To discuss, we've convened a panel of people who work in healthcare. Ryan Miley is a family doctor, a tuberculosis consultant, and the former Saskatoon MLA and leader of the Saskatchewan NDP. He's also the author of a book called A Healthy Society. We also have Michelle O'Keefe. She's a nurse practitioner and president of the Saskatchewan Association of Nurse Practitioners. She works in Grenfell, where she is currently the only primary health provider. And Darcy McGonigal is the president of the Saskatchewan College of Family Physicians. She's a family doctor in Isle of Lacrosse, and she's also a rural director of education for the North with the Department of Academic Family Medicine. All with very impressive titles. Thank you for being here.
Thanks very much for having us.
Thanks for having us.
Okay. So before we dive into Stephen's analysis of the current system and his potential solutions, I would love to get a better understanding for our listeners of what experience you bring to the table. Can each of you tell us currently where you're working and what you do and what your current experience is in the healthcare system as we speak? Ryan, I'll start with you.
Sure. So probably the most relevant to this discussion is working at the Westside Community Clinic on 20th Street in Saskatoon. So we're a primary care, multidisciplinary clinic. We have counselors, physiotherapists, visiting specialists like psychiatry, obstetrics, infectious diseases, as well as a group of family physicians and nurse practitioners all working together. And one of the things that I enjoy the most about that is when a patient comes to see me, they see me, but they also are really seeing our whole team, and it's whoever is able to provide the best care for that patient at that time. That's who we reach out to and connect to. So in a lot of ways, we're practicing a model that sounds like what Mr. Lewis would like to see more of.
Okay. Michelle, let's go to you. What are you doing and what are you experiencing right now?
So I have a bit of experience with kind of both sides of that coin. I was working as a nurse practitioner in Indian Head for the last 12 years. And then just recently, in the last couple of months, I moved my practice to Grenfell, Saskatchewan. And that's where I live. The physician that has contracted services here, their contract was coming to an end. And there wasn't going to be a primary care provider for this community. So I decided, along with getting rid of my commute on a daily basis, that I would start working in Grenfell. So as a nurse practitioner, I've been practicing for 12 years. My registered nursing career before that was in emergency. And similar to Ryan, the clinic that I work in now in Grenfell is multidisciplinary. While the physician contract is vacant at this moment, I also have a fantastic registered nurse that works with me, but there's home care, there's public health, mental health professionals, occupational therapy, and physiotherapy that visit. So it truly is a multidisciplinary team that I can rely on, as well as close links with the community pharmacy. And I'm better able to help serve the community with all of these resources at hand.
Before you moved back to Grenfell for work, though, what was your experience in the previous clinic?
In the previous clinic, it was myself and two physicians, and we were in a standalone clinic offering primary care services. There's also a hospital with emergency and acute care services in Indian Head, but the two are completely separate. So you don't really have that opportunity to quite as easily just walk down the hallway and have a conversation or consult with the appropriate care provider, or get a patient in to see with as much ease the patient person that they should be seeing, as opposed to not always needing to see the physician or the nurse practitioner. Like perhaps this person needs physio or home care or a case consultant with public health.
Okay, Darcy, your turn. Tell us about your current experience where you are in Isle of Lacrosse.
Yeah, so I've been working in Isle of Lacrosse as a full scope family physician for the past 15 years. For anybody who doesn't know where that is, it's in kind of the far northwest of the province, about 5 hours north of Saskatoon. And we are a group of physicians who provide services, both primary care and emergency services, to the community of Isle of Lacrosse and surrounding communities. So we do fly-ins to some reserve communities, and we also do drive-in clinics to Buffalo Narrows and Beauval. So we have a very generalist very interesting practice. We also work in a multidisciplinary team, but not as integrated probably as what Dr. Miley and Michelle are experiencing currently. Probably more similar to her previous Indian Head experience, where there are other healthcare practitioners in our system in the Northwest, but it's not as fluid. I can't as easily get somebody in to see mental health and addictions on the same day, because we don't all work within the same setting. We're in the same building, but we have different systems. So there's much more work that can be done on making us a more integrated multidisciplinary team, and we've been working on that for quite some time. But yeah, that's my current experience.
What kind of area do you serve, Darcy? I know you talked about the fly-ins that you serve, but who do you would, I imagine your the distance you cover is probably a lot more extreme than Ryan or Michelle.
Yeah, absolutely. Where La Crosse is kind of central to all of the communities that we serve, but in that geographical area, there's lots of water and muskeg in between communities. So we have about a 250 kilometer radius catchment area around us, and serve all the communities. So it takes a 15-minute flight or a two-hour drive to get to our furthest community away from us, Pachinak. And of course, all of those patients in those communities they do have primary care clinics. Some are on reserve, so they're covered by the Meadow Lake Tribal Council, and some are off reserve, and those would be covered by Saskatchewan Health Authority. But those clinics also have nurses who work with us very closely. But the distances are far for our patients to travel, and I would say, it's not just physician shortages or nurse practitioner shortages that we struggle with. It's shortages all across healthcare disciplines. So physiotherapy, occupational therapy, almost every single thing you can think of, we are lacking access to those services in the Northwest. I know that's not unique to our area, but I would say it is quite magnified.
No kidding. Okay, let's start with what Stephen Lewis got right. Do you agree, the three of you, that primary health care in Saskatchewan is struggling?
I think that comes without, any understatement. It is struggling, and it is barely keeping afloat on some days.
Ryan, you kind of smirked?
Yeah, it's a bit obvious.
Yes.
That it's a real problem. It's a real challenge for people, even in our biggest centers. Anybody trying to get a new family physician doesn't know where to start. We had a situation where we used to have the list of doctors taking new patients listed online, and when there weren't any, the government decided that they didn't want to post that list anymore. It's really dire, and I think I have some bones to pick with some of Mr. Lewis's approach, but I think the general assessment that there is a need for a systemic approach to primary care is absolutely bang on, and the goal of getting people timely access to care is one we're not achieving at the moment.
I want to share a little bit of my own personal experience in the last couple of weeks, because it kind of led us to having this conversation. I am lucky to say that I have a family doctor, but I waited with an appointment for 2.5 hours to get in to see that doctor for that appointment. And in that time, I saw people walk in who needed care and couldn't get it because he was so backed up. I saw a woman who had an appointment that was supposed to come after mine, who had a 4-hour drive and just needed to get a needle from the doctor and gave up and left. And so she will have to come back and wait again. And I wondered with my producer, what is the benefit of having a family doctor if you are waiting for 2.5 hours for an appointment time? But then the conversation was, would I even get in to see a doctor at a walk-in clinic. So I'm curious, it being in a major center, Ryan, kind of what your thoughts are on the difference between primary care physicians that are a family doctor versus walk-in clinics, and what the models kind of look like in the bigger centers with doctors working in like Regina, Saskatoon, Moose Jaw, that kind of thing.
Yeah, so I think you're always looking at a different experience when you have an attachment to a clinic where you are a patient of that clinic. They have your records. They are the ones who have sent referrals off and are getting the answers back, where somebody really gets to know your history, even if you might not always see the same person at the same time. And your experience, you might not always be seen as quickly as you should be. That has to do with there's a multitude of factors, and every clinic will be a little bit different. How many patients has that clinic taken on? How are they organizing their access? And also, did that doctor get slammed that day? Did they have somebody who was really sick and they just needed to stop everything else because they need to take care of that person? Mm-hmm. That's healthcare. Oh, that's always going to be part of the reality. But I think the really big question, whether it's large center or rural, is that idea that wherever you are, you should be able to access something that is more than just a walk-in, someone who will see you for that 5 to 10 minutes that one time and have no further follow-up, that you can't come back to for answers, that you can't rely on for refills or referrals or whatever other care you need, that doesn't really know your history. We work in a team, and I think that is a model that works really well, where, yes, I have my patients, but I see my colleagues' patients, they see mine. We all access the same charts. We work together. I think that's a necessary part of practice at this time. That's how practice has to be. But there's more for us to dig into, and I don't want to take too much time from the other guests, but more for us to dig into what a working design of primary care would look like.
Mm-hmm. When it comes to filling the gaps, I see more and more nurse practitioners. I don't want to say popping up because you've always existed, but you're getting a lot more attention, Michelle, as the solution in some cases in some of these centers. As a nurse practitioner, how does that feel, and does that meet the expectations of when you signed up to be a nurse practitioner? Is this what you thought you would be doing?
I think it's one of the solutions. I mean, ideally, having a robust system that has enough providers, period, is the solution, but that is kind of a dream. When I signed up to be a nurse practitioner, sorry, I thought I was on mute for a second. When I signed up to be a nurse practitioner, I certainly expected that I would be busy. I worked in an emergency room setting, and I could see from a lot of the patient presentations in that setting that people have certainly not enough access to primary care. While working as a nurse practitioner, a lot of the clinic settings are the caseloads are high, which means your workload is high, and then that takes away from, work-life balance and everything. So like practitioners, whether they be physicians or nurse practitioners, are getting burnt out with the amount of workload and trying to keep up with the pace and feeling that sense of duty to care of, well, this person's in front of me, they're sick, I can't go home, so you have to put off the things that you might do for your own self-care. And the answer is difficult. There's retention and recruitment things that need to happen, but certainly the retention side of healthcare has been lacking in Saskatchewan. And that's something that SAMP has been advocating for and trying to get some of those things in place, because the people that are in the positions and doing the work feel definitely underappreciated. And you look at places like Alberta where the pay is a lot higher, even for a nurse practitioner. And we have members that have said, it's very attractive. And why am I staying in Saskatchewan when I can go to another area and get a much higher wage and perhaps a better work-life balance?
I'm Sam McKeag. Today we are talking about fixing healthcare. What is the solution and what are the problems when it comes to primary care? We'd love to hear about your experience. You can give us a call, 1-800-716-2221, or send us an email, bluesky@cbc.ca. We have a panel of healthcare workers joining us today. I want to give a little bit of a history lesson here because in his op-ed piece, Stephen Lewis talked about the legacy of an agreement made in 1962. He says that's when Saskatchewan doctors were, quote, dragged kicking and screaming into the Medicare era after a bitter 23-day strike. He goes on to say the strike ended with the Saskatoon Agreement, which made 4 major concessions. They would not be employees. They could opt out of Medicare. They could choose how to be paid, and they would practice where and how they see fit. There is a lot there. But let's start with number 4, practicing where and how they see fit. Darcy, what do you make of the idea of having a pool of doctors and then assigning them to places where they are most needed?
Yeah, I think that is not a very popular solution to the current primary care problem. But I think more importantly, Mr. Lewis kind of didn't really address the fact that there has been a lot of change since 1962, and his view of that is just the way that doctors are being paid currently is very out of context and out of date for what's actually happening. I think all 3 of us have talked about that we're in different types of practices. I for one, am not in a fee-for-service practice, and there are many physicians, especially in rural and remote, that are not fee-for-service and do not decide everything about their practice setup. I do fully agree with him that changes need to be made, but changes are starting to be made. And I think his view that if we went to a system where SHA kind of was in charge of everything, we already see that a lot in our rural and remote areas where the SHA holds primary care contracts that physicians have, and still that hasn't fixed the problem. But this idea that physicians are completely in control of their current practices across the board is false, I would say.
Is there anything you'd add to that, Ryan?
Yeah, I do think that the degree of blaming doctors there is, there's a reflex where we're kind of big fish in the medical system, and so sometimes people want to point as doctors as the problem. And there are historical ways in which medicine has been structured that do allow physicians to go where it is where you make more money, where you see easier patients. You can hang up your shingle wherever you want, and there have been incentives that don't add up to care being provided where it's most needed. I think the other part of that to understand, though, is that that's also how the system has limited the opportunities for people to work where the care is really needed. For example, I work at the community clinic. We're salaried physicians. We get a certain number of positions for our clinic. If we want to hire more doctors, we have to go cap in hand to the government and say, we need another doctor here, we need another doctor there. And they don't really jump at the chance to provide more. Whereas if somebody says, I want to practice down the street, they can open their office. So in some ways, we have seen generations of governments of all stripes actually limit the degree to which a primary healthcare system could be developed. And I think that's where the work really needs to be done. I thought the response about could we lose doctors, it's possible, was a bit blasé, right? Absolutely. If you suddenly came in tomorrow and said, this is the system and you're working in it or get lost, they'll get lost. You need to actually build the kind of jobs that people want. Where I did agree with Mr. Lewis and agree strongly is that the kind of jobs he's describing, the kind of jobs we have, are the kind of jobs that new grads want, that new doctors coming to Saskatchewan want. They want to work in group practices. They want to work where the need is there. But those positions also need to be attractive economically and work-life balance, as Michelle described.
In that,
I want to just, if I might just add one thing, and I want to point our readers and listeners and viewers out to one resource I think is really worth looking at, which is a book by Jane Philpott called Health for All, where she talked about how we could rebuild a primary care system for Canada, or build one. And she used the example of schools. If you move to Isla Crosse, if you move to Saskatoon, if you move to Grenfell, and your kid wants to go to school, you don't have to get on a waiting list. Your kid just goes to the school. But if you want to get a care provider, you might have to be on a waiting list or not find one at all. Reorganizing a system with new jobs for doctors and nurse practitioners and whole teams to be providing primary care based on that geographical location, that if you live in a place, you're going to have care. I think that's a really good organizing principle that we could look at as a way to build the kind of system that draws care providers in order to be able to provide for patients.
I think there's something attractive too about knowing that if you move to a smaller center, that they have medical care for you, that you're not going to move to a smaller town like Grenfell and know you're going to have to drive the 45 minutes into Regina just to see your doctor to get a refill on your allergy meds. There's something I think attractive about that. I want to ask you about the group clinic mentality with new grads. Is there an opportunity there too for mentorship and understanding? I think in opening those individual fee-for-service clinics, I don't want to say you're getting in over your head, because obviously you have gone through medical school, but I think there's something to be said for having that group, that ability to bounce things off other people who've been doing this longer than you, versus opening a clinic on your own and, hoping that it goes well.
I'd love to hop in here. Yeah. I think with my involvement with the Department of Family Medicine, we definitely see that. We see a lot of new grads coming out who are moving away from joining longitudinal care type practices, and we're seeing them go into more focused practice. And it's for that very reason. A lot of them have trained in a group team-based setting, multidisciplinary setting. They've seen how well that can work. And if they want to stay in an urban center, a lot of times those positions are not available. As Ryan said, that we've seen there's been limitations to these group primary care models set up in urban centers especially. So we're really kind of like, moving our great family medicine doctors who are fresh out of residency away from that type of practice. And that's the type of thing they want to do. Ryan was talking about Dr. Philpott. They did do a pilot project of her type of vision in Kingston, Ontario. And they have no problem staffing that clinic with new grads coming out because they've trained there, they've been mentored there. They see how working with nurse practitioners, social workers, physiotherapists right in the clinic is so important and beneficial for their patient population. And I think they've taken so much pride in being able to provide care for a whole bunch of patients in their area that have been waiting for years for attachment with primary care. So I think that's a really amazing success story, and something that we definitely should be looking at to replicate.
I think this is one of the things that has been huge for nurse practitioners, especially when you have a new or novice NP and you're going into a community that hasn't had a provider. Maybe the NP position has been vacant for 3-4 years. These community members have a significant amount of chronic disease that may not have been managed to this point, and that it can be very overwhelming when you're starting a new practice yourself. like along the highway here, I mentor the NP in the next community over because she is a newer hire and I've been here for a while. So you do have some of those informal things set up. But what SAMP did a few years ago was we developed the SAMP mentorship program so that any new grad could apply to have a mentor, and then that person is matched based on geographical location and practiced area interest to be paired up for a year so that they have a consistent mentor that they can reach out to if that is something that they're looking for.
Darcy, is that something that the College of Family Physicians tries to do too, is set up recent grads with people who've been doing this for a long time so they don't feel like a fish out of water in an area that they may not know?
Yeah, it actually isn't something that my organization does. But I mean, informally we do. But there is actually a program set up in the province called Compass for physicians, new physicians, early career physicians, especially important for new physicians to Canada. And they can request to have a mentor. My husband's actually a family physician, and he's a mentor for that program as well. And it's fantastic because it allows not only some support for clinical guidance, but also that kind of coaching and kind of career guidance that a lot of people struggle with in the first 5 years of their practice. But we definitely, there's lots of informal mentorships that go on. In my practice, for example, because we are a rural, remote, very challenging family practice to join, we take a very group-based mentality. Anybody new who comes in, we support them heavily because we know that that's the way that we can kind of keep physicians in coming back. But as Michelle said, it does get challenging to provide that type of service when you have a chronically understaffed healthcare system where people are feeling strained. It can be hard to have a rosy outlook on how things are going and to mentor somebody when you yourself are struggling with your current workloads.
Ryan, we were talking a little bit about that unpopular solution with, if we do this, then they'll leave. What would doctors be giving up if primary care was managed by the SHA specifically?
I think you would look at what are some of the things that would be given up are choice of location, choice of practice, deciding how many patients to take on, et cetera. And you certainly do see that in jobs where there is a salaried position or other models that aren't simply fee-for-service. So it's not as though that isn't an experience that physicians have, and as Darcy points out, would have come through their training having had that experience as well. For me, I think that's not the huge barrier that it might be imagined to be if the job is an attractive job, if it's coming with those supports to be in a clinic where you have the facilities necessary to see patients, you have the colleagues with you that you can work with and be mentored by or mentor to, and that you still have the ability to practice medicine based on what you think is right, based on your understanding of the evidence, and based on what you see as your patient's needs. And that's where I think the autonomy issues are bigger, at least for my opinion, the autonomy issues are bigger when it comes to being able to listen to your patients, use your best knowledge from your training and your understanding of the evidence to provide the care they need without the interference of the SHA. And my experience, or whatever body it is that has hired you, and my experience is that tends to be the case. And I would hope that would be the case in whatever system was designed here. The upside to trying to create a system is that you would get rid of what we have, which is this complete mismatch. Think of a community like where Drs. McGonigal works or where Michelle works. There's not enough providers for people there, but there are other areas in our province where there's loads of providers, and it's not even the highest needs areas. We have not figured out a way to smooth out that response to need, and that's where I think a public publicly funded and supported system of clinics, of primary clinics. And I think, again, along that geographic model could be much better designed to say, and I heard this from Mr. Lewis's comment, the evidence says the people who are sick are here, the people who have needs are here. Let's get the providers in the same areas as them so that's who we're taking care of.
So there's clearly a need for more staff. That is what I'm hearing from everyone. It's not just that we don't have people in places, it's that we don't have the people at all. So where do we get them from? Because this is an issue right across the country. Do we need to train more? And when I say more, I mean nurse practitioners and physicians. Is it a case of other countries who do have a medical degree and haven't been able to get recognized here? Like, we'd be pulling from other provinces. So what is the solution in terms of the work and finding people to do it?
It's trying to fill a cup of water from an empty bucket. Like, there isn't the people. So one of the things that we've seen with nurse practitioners is you might have a nurse practitioner that is licensed and ready to practice, and they live in a rural community that there is not a position available. That is where they live and they want to practice. There is a medical need. So that's why we were working with the Ministry of Health to develop the primary care nurse practitioner contracts to, alternate funding mechanisms has been something on our radar for the last decade or more. You need to make the position where the need is so that you can put the person in it that is there and wanting to serve. You look at retention and recruitment bonuses that other provinces have, and certainly when it comes to nurse practitioners, there's a significant difference. Like, I'm from Newfoundland, and if I were to return to Newfoundland, my signing bonus for a position that is 20 minutes from my parents is $140,000 for a 3-year commitment. And there's nothing like that in Saskatchewan to compare. Like, if you're working in a position with the health authority, and then you move to even a rural or remote location like I am in now, you're already an employee of the health authority, so you don't qualify for any of these recruitment initiatives. They're there for new employees.
So there's no incentive for people who are in big centers to move out to these areas that so badly need the healthcare providers.
A currently employed nurse practitioner that is already working for the health authority, no. You're already an employee, so you are not considered to be new, so it's not an incentive. So really, what needs to be looked into are retention projects for these type of settings, or to extend that initiative to people that are already employees in a larger center that want to recruit to one of these smaller communities, have those initiatives be able to be used there as well.
Darcy, what about the North? The North struggles in so many ways, but particularly when it comes to finding all kinds of support. How do we get more medical care, more nurses, more nurse practitioners, social workers, all of that into the North?
Great question. I wish I had a complete answer, but
what do you think would work from your experience?
Yeah. Well, I mean, Michelle just mentioned some of those recruitment and retention strategies for nurses and nurse practitioners. I've heard lots of my nursing colleagues talk about that very thing, that, hey, I've lived and worked here for a really long time, but I don't really get any benefit from that. But if I hop a province over and sign up with them, then I'd get a huge signing bonus. So I think that's something that's really not been focused on. I think if we're specifically talking about the nurse practitioners in our teams in the North, I think that, again, there haven't been enough positions opened up in a lot of our communities, so that they're chronically overworked and understaffed. Instead of setting up a true multidisciplinary system in some of our communities where those nurse practitioners are supported, they're not doing 1 and 2 call for 2 weeks in a row, and expected to do that for years on end. And that in and of itself burns people out over time. And so if you don't kind of build the system as we've been talking about, invest in that primary care, invest in those multidisciplinary practices, then you're never going to be able to attract people and keep them. You might be able to attract them. I agree with Mr. Lewis in that continually increasing pay is not the answer. We've seen really lucrative contracts in rural and remote locations, and that isn't keeping people there. It's not just the pay. You have to make sure that people's work-life balance and working conditions are reasonable, or else they're going to find somewhere else to go.
I want to go to the phones. Wayne is on the line in Beaver Flats. Wayne, go ahead.
Yeah, I just wanted to say that this problem has been going on for decades now, and it's getting worse because we have an aging population, and I'm one of those seniors. And with that, we bring a whole lot of other health problems. And I think that in the last couple of decades, we've seen a lot of investment in economy building and bricks and mortars. And I think what we need to, we have to have some kind of an administration that really understands the importance of human resources. And I wanted to touch on, when I was a social worker in the North, one of the things that attracted me pretty well right out of university many years ago was the NDA and Northern District Allowance. And it helped because the cost of food, housing, and it's come a long way. And one of your guests said that money isn't the answer. It's not the answer, but it's a big part of the answer. Money talks, and also length of contracts. I signed a 5-year agreement to stay in the North, and that was the beginning of my 10 years in the North. Mm-hmm. The NDA, and also being obligated. And if I broke that service agreement, then I had to reimburse certain things. So I think we've come to a point where these Band-Aid solutions, we now know, aren't working. We have to have an administration that really understands the importance of significant, well-thought-out human resource strategies to recruit people and keep them here for a lifetime.
Wayne, thanks so much for
that. Yeah.
Thanks so much for your call. I appreciate it. We're just coming up on the end of the show here, and I think that our guests were nodding along with a lot of the things that you had to say, and I wish that we had more time, but unfortunately we don't. I feel like we could solve the world's problems here, but without the bank account and the elected powers that be, there's not a lot that we can do, but we can hope that those that are elected are listening. Thank you, all three of you, for your expertise and the hard work that you put in to caring for your communities. I so appreciate your time and your expertise, and I'm sure we'll talk again soon. Thank you so much.
Thanks, Sam. Have a great day.
My guests today were Dr. Ryan Miley, who's a family doctor in Saskatoon, Michelle O'Keefe, who's a nurse practitioner and president of the Saskatchewan Association of Nurse Practitioners. She's in Grenfell, and Dr. Darcy McGonigal, who is the president of the Saskatchewan College of Family Physicians, who's also a family doctor in Isle La Crosse. Lots of things to consider there. If you have thoughts, you can always call Talkback 1-800-661-7540 or send us an email, bluesky@cbc.ca.